Um, so I'm just going to start the session. Hi, my name's Zarat. I'm one of the ST3 histopathology trainees. So today my talk is on the basics, very basics of skin pathology. And this basically will give you a bit of an insight, hopefully, into what we do as pathologists on a day-to-day basis. Skin specimens make up, a huge amount of work for all pathologists everywhere. So hopefully this and you might have had some experience in histopathology as medical students, and you would probably have gone through the kind of anatomy and things like that. So this hopefully would give you that translation between what you have read and what we actually see on the slides as histopathologists. And maybe you can learn something and maybe be inspired to do histopathology. Right, so, yeah, fine. So the skin, just going to the very basics, is mainly divided into the epidermis and the dermis. So the epidermis is the kind of more thinner layer at the top, and what we actually see from the outside as skin. And then we have the more thicker, more connective tissue layer in the dermis, and after that you have your subcutaneous fat and muscles. So I'm pretty sure all of us had to learn all the layers of the skin, the 5 layers of these epidermis. And it always, as a medical student, it never made sense to me, like, what are the different layers? Why do they have different names? Why are we learning about them? But I'm going to try and just sort of simplify that, because it is important to have like an understanding of what's going on in the normal skin. So if you know what normal is, it's much easier to know what's abnormal. And as pathologists, it's obviously our job to see, to comment on what's normal, what's abnormal, because that's the kind of questions the clinicians are looking for from us. So even though when we look at a skin slide, we start from the top, from the stratum corneum, and work our way down. But to understand what's happening, it's best to start at the basal layer, the stratum basale, this sort of thin layer at the bottom of the epidermis. So this is where you get your sort of young keratinocytes, and this layer is continuously dividing. So you have, and these cells, they're called keratinocytes. So the keratinocyte stem cells are present here. So if you think about it, dividing lots and lots and producing lots and lots of cells. Now these cells, as they grow older, they sort of go up. And here, as you can see, they become quite plump. So if you can appreciate here, so these are the kind of nice round nuclei that these cells have, which are a bit dark purple. And then around the nuclei, they have this nice bit of plump cytoplasm, very pinkish cytoplasm. And this is your stratum spinosum, so you have the spinous layer, and these are where the nice, young, fresh, vibrant keratinocytes like to hang out. And I'll show you in a bit a more detailed picture of why it's called the spinous layer. And then as they grow older, they grow more mature, and they go up to this layer, the stratum granulosum layer, and they have granules in their cytoplasm, and that's why they're called the granular layer. And again, I'll show you a close-up of the granules. So then they form this thin, more purple, darker granular layer. And finally, these cells, they have matured, they have lived their life, and they basically die. And when the cell dies, what happens is they lose their nucleus, and they become this thin kind of fibrils, filaments, which is your keratin, and it's in the stratum corneum or the corneal layer. And this is what we see from the top, the keratin. And this is what you shed every day. And this process keeps happening. So new cells rises up, they die, they form your keratin layer, which forms the protective barrier. Um, and this sort of continuously repeats itself. So that's the epidermis. Oh, sorry. What's happened? So this is just a close-up of the cells in the granular layer, and you can see these tiny granules in their cytoplasm. This is what gives them their names and makes them look slightly different from the cells in the spinous layer. And then this is our young, fresh, vibrant spinous layer, if you remember. So nice, round nuclei. They have lots of pink cytoplasm. And if you can appreciate these kind of spines in between the cells, so around the cell membrane, so the cells basically hang on to each other because of these spines. So they help to sort of anchor the cells to one another. And this is where it gets its name, the spinous layer. Now, it's important to know the layers and what they normally look like, because once we know what normal looks like, then we can appreciate what the abnormal looks like. Right, so depending on which part of your body the skin is, so you can have thin skin and thick skin, and thick skin is usually the palms of hands and the soles of your feet. You can have one extra layer, which is the stratum lucidum, that is usually only present in thick skin. And so when we're looking at skin under the microscope, because of the stratum lucidum and the thickness of the keratin, the corneal layer at the top, we can usually tell if it's from an area that has thick skin. And that's sometimes important because sometimes we don't get a lot of history about where the skin is from, or any clinical details, so we are able to tell under the microscope. And this epidermis sort of goes down into extensions. There are little extensions of that into the dermis, which is again normal, and they're called the rete ridges. And again, that's important because these rete ridges become flattened, which can be a sign of pathology. They can become more elongated, again, which can be a sign of a disease. Okay. Right, so we talked about the keratinocytes, which are the main cells of the epidermis, that they are the ones that make up the epidermis. But there are also other cells, and another important cell are the melanocytes, which you would have heard of. So these cells, they look slightly different to the keratinocytes. If you can appreciate, their nuclei are much darker than those of the neighboring keratinocytes. And you can see this nice clearing. So where these cells, the keratinocytes, have nice pink cytoplasm, instead, these have a clearing around the nuclei. So these are the melanocytes. And melanocytes, again, you'll know they produce the melanin pigment, which gives our skin the color, but they don't store the pigment. So actually, you can see some brown pigment here within the keratinocytes. So the melanocytes are basically just the kitchen. They're producing it, but then it goes out into the keratinocytes. So it's the keratinocytes who end up sitting with the pigment. And then there are other dendritic cells and Langerhans cells in the skin as well, which we won't be able to see under light microscopy. It's only when we do special stain able to see them. Now, when we come into the dermis, so this is mainly your connective tissue layer. So the top bit of the dermis is the papillary dermis, and then we have the reticular dermis. And this is where you find the other sort of accessory structures of the skin, which are very important for its functions. So you have the sebaceous glands, which produce sebum, so like these large pale areas like that. So that gives you your oily skin. You have the hair follicles, so which produces the hair on your skin. You have erector pili muscles and lots of other glands, which are all basically part of your skin. So that's what the normal skin looks like in a nutshell. There are some changes we can get in the skin, which may happen in a normal skin. So, for example, if you can appreciate here, so if we just go back, so if you look at this here, so it's nice and pink and linear, and you can see how it looks like the fibers are kind of smoothly going across. Whereas here, if you look at this area, so these areas are more bluish purplish staining. So they stain a bit more blue or purple, and they are a bit more haphazard. If you can see the sort of filaments and fibrils here, they're just sort of haphazard, not as nice and linear as we saw before. So this is basically sun damage, what we call solar elastosis. It basically means sun damage, but in histopathology we like fancy words. So um, we call it solar elastosis. And this is normal. This is an age-related, sun damage-related process. So your sunlight basically destroys your normal collagen in the skin, and this is what leads to that. And this is what gives you wrinkles and things like that. And it can be perfectly normal, but again, they sort of help us. They give us clues if we're thinking that the person has a disease in the skin. They give us clues. So a big part of being a pathologist is being a detective. We're always looking for clues, whether it's clues from the clinical history or clues when we're looking at slides under the microscope. And these are the kind of small things we just sort of collect. And then that helps us reach the final diagnosis. So next, this is one of the most important jobs we do. We separate benign from malignant cells. So we say what's benign, we say what's cancer. And again, this is not a hard and fast rule. This doesn't apply to, every cancer, every organ. But in general, when we are talking about malignant cells, they tend to be a lot more ugly. No offense to malignant cells. They tend to be more ugly. Their nuclei tend to be larger, more irregular, and the nucleoli tend to be more prominent. They have high nucleus to cytoplasm ratio, so they have less cytoplasm, and the nuclei are larger, and they have a lot of mitoses because these cells are always dividing, the cancer cells. So they have a lot of mitoses, and they can have some abnormal mitoses as well. So here you can see the nuclei are not nice. So some of them are oval, some of them are a bit odd shaped. And then these are the mitoses, so these dark figures, so they're mitoses. So when we see sort of these things, we are worried. We know that they're atypical cells. And finally, a lot of other things sort of come together before we say, this is definitely malignant, but these are the things that makes us worry. Right, so I don't know how many of you are online at the moment, or if you are sort of willing to participate. So I have some cases that we can work through together, and just sort of, these are some of the basic conditions we see in the skin. And it will also sort of give you a framework, and the kind of framework we use to look at slides. And there are lots and lots of nuances to this, obviously. This is just a very, very basic framework. So, the first case, this is from a 68-year-old man who noticed this lesion on his back 6 months ago, and it has grown slowly. So again, the clinical information we get, as we said, we are detectives and we're always looking for clues. So again, the clinical information we get gives us a lot of clues. So the fact that this is a 68-year-old man who has a skin lesion, it increases our suspicion, increases our worry, because the older you are, the more likely you are to get more malignant conditions, cancers, whereas the younger you are, the less likely. Again, this is not a black and white. This is not a yes or no rule. Young people do get cancer, older people do have benign conditions, but these are all, as I said, little clues that sort of we tie together at the end to reach the diagnosis. And then it has grown very slowly. It started 6 months ago. So that kind of reduces my level of suspicion, because cancers usually tend to grow very fast. Again, not a hard and fast rule. Lots of slow-growing cancers out there, but in general, this is a skin lesion that has grown very slowly. So as you can see, it is pigmented, so it's darker than his skin, and it is very irregular. So you can see these little mounds. So we take a biopsy of that and we process it, and this is what we see under the microscope. So we can appreciate that this is quite different from the skin, normal skin we saw initially. So the sort of framework I use to kind of work through this is basically, you can think of it as answering some questions. So these are the kind of questions you can answer, and if you answer these, you might be able to sort of take all of that information together and reach a diagnosis. So first of all, we'll start at the top. We always start at the top, look at the keratin layer. So is the keratin layer normal or abnormal? And if anyone wants to, you can put in the comment what you think. But because I can't see the comments, this is going to be quite difficult. So I'm just going to talk through, but feel free to put in the comment what you think. And then, it just helps you to work through the cases and maybe makes it a bit more interesting. So the keratin layer at the top, so looks quite okay here. Here, maybe it is a bit thicker. And then we want to see where the abnormality is. So as I said, there is the epidermis and then we have the dermis. So I know that we can't see much of the dermis, but we can definitely see that the epidermis looks much thicker than it normally would, than the slide we saw before. So I think we can safely say that the abnormality is in the epidermis. Then we're trying to think, what are the cells involved? So the two main cells, if you remember, we said the keratinocytes, which has the nice pink cytoplasm, and the melanocytes, which have the clearing around the nuclei. So if you look at all these cells, so they look like they have lots of nice pink cytoplasm. Doesn't appear to have any clearing. So I think we can say here that these are the keratinocytes. And then we want to know if there's any special features or any sun damage. So I know we can't really see any dermis to appreciate any sun damage, but there was no sun damage. And especially in the back tends to be an area where you don't get sun damage very often. And special features, I think hopefully most of you are questioning now, what are these things? Because these are not what we saw before in the normal skin. So these are these cyst-like things with actually this keratin, and this things within these cysts look very similar. And they are these keratin. So the keratin at the top, this is the keratins within it. So we have some keratin-filled cysts. We have a much thicker epidermis than we would expect, lots and lots of keratinocytes. So something is happening. And then the question is it benign or is it malignant? Now, if we try to use the criteria we have learned, that the malignant cells tend to be more ugly, larger nuclei, we can't really see any of those features here. They all look uniform, small, not a lot of ptosis. So at this point, I'd probably say, okay, we're leaning towards benign. So this is actually a very common lesion. If you are in GP, if you sit in with GPs, I'm sure you see lots of elderly people coming in with that. It's a seborrheic keratosis. It is a very benign condition, and it's where the keratinocytes basically proliferate. So there's lots and lots of them. You get the thickened epidermis. And you have these horn pseudocysts. So these kind of cysts filled with keratin. This is the hallmark. And it is very benign. You don't have to do anything. You don't even have to cut it out. If you want to cut it out, it would be for cosmetic purposes. But it can just stay there. You can have multiple of those. No, there's no worries about these. They do not transform into anything malignant at all. So very common skin condition and one of the basics. Right, so we go on to our next lesion. So this is an 80-year-old female, again, quite elderly female, and they have a lesion on their forehead. So forehead, I'm automatically thinking this is an area that is exposed to the sun a lot. So, more chances that there would be some sun damage. If you look at the lesion and compare it to the previous one, so like it doesn't have the dark pigment like the previous one, it's more pale and actually a bit scaly looking. And this is what it looks under the microscope. So again, if we sort of use our criteria, from the top, again, the keratin layer looks fine. And if we try to think about where the abnormality is, it's actually, if you look at the basal layer here of the epidermis, and maybe I can convince you that it doesn't look as nice and pretty as the basal layers we have seen before. They look a bit haphazard. They look like something is going on there. It's just not quite nice because it's usually, in a nice line like a fence. But here, actually, especially if you look here, that just looks, and some of these nuclei look much darker, and these cells look like they have less cytoplasm. So I think we can say that the problem is in the epidermis. And again, if you can appreciate these purple chunks, again, it's supposed to be nice and pink and smooth like here, but then we have these purple chunks. So that is our sun damage, our solar elastosis. So we expected it to be sun damage, so sun damaged skin. And we have an abnormality in the epidermis. Now, which cells are affected? So again, if you look at the cells close up, these are the cells with the pink cytoplasm, no clearing. So we know that these are keratinocytes. So we have a problem with the keratinocytes in the basal layer of the epidermis, and there is sun damage, associated sun damage. And these cells might not look like the ugliest cells ever, but they don't look nice and normal. So again, if we sort of go back and if you sort of appreciate, so these are the cells here, nice and normal. But if you look at the cells here, they don't look as nice as that. And again, you need a bit of training of your eye and you need a bit of imagination. Actually, you need a lot of imagination to do histopathology. But so they don't look as nice. So I am worried about it. I don't think it's benign, but there is an in-between benign and malignant where the cells can be atypical, but they're not malignant yet. So this is actinic keratosis, and this is the in-between that I was talking about. So it's a keratinocytic lesion. It is secondary to sun damage. So the sun damage is very important here because you cannot diagnose actinic keratosis if there is no sun damage. And it is a precancerous lesion. It's a precursor to squamous cell carcinoma, which you may have heard of. And you see these atypical, so we call them atypical cells, which means they're not normal, they're worrying. They might be malignant or they might be this in-between dysplastic cells. And we saw the crowding and the overlapping. So that's actinic keratosis. So seborrheic keratosis, completely benign, fine. The cells look normal, whereas actinic keratosis, this again, the cells look abnormal, but it is only in the basal layer and it's not cancer yet, but it is a precancerous lesion. Okay. So the next one we have, I'm just going on the time. Okay, right. So next one, 75-year-old female, and there is a dark spot on the face that she's no spot. And again, very, very common lesion. And as you can see, slightly pigmented, not as irregular as the seborrheic keratosis, no crusting like we saw in the actinic keratosis. And this is what we see under the microscope. So looking at the keratin layer, maybe there is a bit more keratin than we expect. But this, again, looked different from what we saw before. So I think, again, if we want to localize where the problem is, where the lesion is, I think we will all say the epidermis. And if you remember, I said the extensions of the epidermis into the dermis, they're ET ridges, and sometimes they can be abnormal. So here, these VT ridges are more elongated. They're more elongated than we would expect them to be. You can see there's a lot of pigmentation along the keratinocytes in the basal layer. Lots and lots of brown pigment. And in the dermis, again, we can see this purplish bluish areas, haphazard areas, which is our sun damage. So we know it's a sun damaged skin. We know the problem, the abnormality is in the epidermis, and that has caused these VT ridges to become quite long as well. And now, which cells are the problems? So if again you can appreciate that these cells, they have the clearing around the nuclei, and you see these are the melanocytes, and there's lots and lots of them, and you have to take my there's a lot of melanocytes. If you can sort of think back to the previous normal skins or even the abnormal skins I've shown, you don't actually have that many melanocytes. Sorry, I went the wrong way. Yeah, so here we don't have that many. You don't have that many melanocytes. The majority of are the keratinocytes, but actually in this here we have lots and lots of melanocytes. So we know the abnormalities in the melanocytes. Now the question comes: is it benign? Is it malignant? Is it in between? And again, if you can sort of think back to the normal melanocyte I've shown, that and this actually looks pretty similar. Again, you know, there's nothing ugly about these cells. They're not large. They're very different from each other. And they just look normal. There's just a lot of them. There's a proliferation of melanocytes. So I'm tempted this is more benign. This is lentigo simplex. It is a benign melanocytic proliferation. It is due to sun exposure, but it's completely benign. You have lots of melanocytes, you have lots of pigment, and the VT ridges become elongated. And this pigment on the VT ridges, it's called the dirty paw pattern or dirty socks pattern. And so this is what, so it's supposed to be, if you think about paws of like puppies dipped in chocolate, that's what it's supposed to look like. So because this is such a visual specialty, we use a lot of descriptive terms, and that's one of them. So this is just what, you know, normally we would call a sunspot, but in histopathology we call it solar lentigo, but it's basically a benign sunspot. Okay, so then we come to a more funky looking lesion, if you will. So it's an 89-year-old patient, again older, and it's on the cheek, again an area that is very exposed. And in a few months, the lesion has become quite big, or quite prominent at least. So age, we're worried site, we're worried because it's sun exposed, and the quick growth is worrying as well. And you can see there's a nodule, there's some nice rolled edges, and even in the middle. And this is a very typical description of what it is. I'm sure you've all read about it, but this is what it looks like under the microscope. So again, if we just sort of stick to our mat, the keratin layer at the top, fine, not to worry about. And then in terms of where the abnormalities, I think we have a very big abnormality here in the dermis. Is there any solar elastosis? So again, if you kind of look at these areas, which look more purpley, bluish, so we do have sun damage as we expected. What cells are these? And I know what you're thinking. These cells don't have, but they also don't have the nice pink cytoplasm of the keratinocytes that we saw. So what cells are these? So these are actually the keratinocytes in the basal layer of your epidermis. But as you will see that they have lost a lot of their cytoplasm and the nuclei look more blue. And if you can appreciate, the nuclei don't all look nice and round. Some of them would look a bit angrier. It's not the ugliest thing ever, but it is not normal. And there are loads and loads of them, a lot. And there's this huge nodule, lots of these nests of these very blue keratinocytes, which is mainly the nuclei. So I would think everything put together makes me think of something malignant. So this is your basal cell carcinoma, and it is the most common malignant tumor in humans. Lots and lots of people have them, especially elderly people. And it's locally aggressive, which means it can become quite large, but it never metastasizes, so it never goes to any other organ. The treatment for this is excision. So you take all of the carcinoma out. You make sure that there is no carcinoma around the edges of what you have taken out. And as long as you have taken everything out, you're good, you're in the clear. So again, very common carcinoma wherever you are, whatever specialty you're doing, you'll end up seeing these. So another picture of basal cell carcinoma. So you get these nice lobules, very blue looking. Okay. So obviously you can see that we are kind of going in the malignancy scale. So we have a 90-year-old man, right lower arm, and it grew rapidly over a month, and it's painful. So again, age worrying, arm, again, these are sun-exposed areas worrying. It grew very rapidly into this large, very ugly-looking thing. So again, worrying, and pain is worrying. So this is what we see under the microscope. So keratin layer, it's much, much thicker than what we have seen. In fact, it looks as thick as the palms of your hand or the soles of your foot, but we know it's not from there. So this is abnormal. This keratin layer would be normal if it was taken from the sole of your foot. Because it's from the lower arm, we know this is abnormal. Now, where is the abnormality? So this is, I think you can appreciate, is obviously normal, something going on in the dermis that shouldn't be there. Here as well in the epidermis, again, that looks a bit abnormal to me. And again, the epidermis is much more thickened, and it looks like something is going on there. So you can have abnormalities in both the epidermis and the dermis. So this is, in this case, I think that is what we're dealing with. Any sun damage, you can see this nice bluish purplish sun damage here on both sides. So we have lots of sun damage. And what cells are to blame here? And I think you'll appreciate there's lots of pink cytoplasm and even the cells dying to produce keratin. So these are our keratinocytes. However, these keratinocytes do not look nice at all. They look ugly. They are sort of very haphazard everywhere. And if you look at the nuclei, some of them are round, but not all of them. Like here, they're more elongated. You can see some are darker. And you can even see some mitotic figures. So it's a bit hard to see here, but there are some mitoses here as well. So that, again, to me looks very, very malignant. And this indeed is squamous cell carcinoma. So this is much more aggressive than your basal cell carcinomas. So this is your keratinocytes that undergo sort of differentiation and become these malignant. And we sort of grade them, and according to the grade of them, their prognosis changes. And there's a lot of other things that affects the prognosis, but they tend to be more aggressive. They do metastasize, so they do go to other parts of your body. They can sort of go into blood vessels, they can go into lymph nodes, they can travel to other parts of the body. And excision is the first sort of treatment, but they might need extra radiotherapy and chemotherapy as well. And the sort of hallmark of these squamous cells is they do tend to look like the squamous cells. So the spines, if you remember, these are called intercellular bridges, the spines of the spinous layer. So they're dying and producing keratin and lots of pink cytoplasm. So that is your squamous cell carcinoma. So again, here, I think you can see that they just look ugly. Okay, so I think this is one of our last cases. So this is a 60-year-old female, lesion on the upper chest, and it has rapidly grown in weeks, and the color has darkened. Now, if I'm sure all of you know about this, and if you know about this, you will know that this history is very worrying, because we can see it's an asymmetric lesion. There are lots of color variations. The borders are not nice. They're irregular, and it has grown very rapidly, and it's more than 4 millimeters. So all of this nicely kind of fits into your ABCDE of signs of a melanoma. So this is what a melanoma looks like. And again, if you sort of use your format, so keratin looks fine. Where is the abnormality? It's in the epidermis, but it's also in the dermis, if you look at it. So there are melanomas can be related to sun damage, but there are also melanomas which don't arise from sun damage at all. So that is not necessarily a helpful factor when we are looking at a melanoma. And which cells, of course, are nice clearing. You can see the nice clearing around the nuclei. Our melanocytes are to blame. So melanocytes, but just look how abnormal they look, how ugly they look. They're not uniform at all. Some of them have these large nucleoli, these darkened areas within their nuclei, mitoses, mitoses, mitoses. You can see some pigment. Again, mitosis there. It looks very, very ugly compared to the nice melanocytes we saw before. So this is, so we worked through all of that. So this is a malignant melanoma. And it is 1% of all skin cancers, but the incidence has risen rapidly. And it is usually in sort of older patients, but sometimes it can appear in younger patients too. And I think that's it. So this was a just quick quiz at the end. But again, I don't think we're able to, because again, I can't see the comments. So we will just, it's something you've seen before. So I'll give you maybe, a minute to write down what you think. It's one of the conditions we have just seen. But I'll just say keratin layer is fine. The abnormality seems to be in the dermis. There is some sun damage here and here. And then you see these kind of large lobules of very blue cells, so very blue purple cells. So if you can just commit to a diagnosis. Yeah, so that's, hopefully you've all gotten it and you didn't fall asleep. It's a basal cell carcinoma. And I think that's the sort of end of it. So these are some of the references you can use. They are quite good for if you want to just sort of look up, histopathology of skin, even if it's like normal histopathology of any organs, really. And then dermnets.org, they have sort of nice summaries of all the kind of dermatological conditions, which is quite helpful. And that's it, I think, from me. And if there's any questions, I'm happy to take them. Otherwise, yeah, that's all done for me.
Thank you so much, Dr. Zarat. That was a really useful talk about dermatology. Thank you so much.
No worries.
We'll end the stream there if that's okay. Thank you.
Yeah, brilliant. Thank you.
Hi, sorry, Zarat, it's Stephanie.